Yeah, I just started the recording. Okay, so you'll notice on that last lecture there aren't as many practice questions, and that's just because I ran out of time. We have a block exam on Monday too, so my plan is to cover I think it's two remaining lectures on Sunday, and then I'm going to try to write a bunch more practice questions. Okay. All right, so starting with the intro to the antimicrobials lecture. All right, so first important thing here that you want to pay attention to is the difference between prophylaxis and empiric versus definitive therapy. So prophylaxis is used to prevent infection during invasive procedures or to prevent transmission in persons with increased risk. So the example that she used during lecture was, if a parent brings their child into urgent care and the child tests positive for influenza, then you can prescribe the parent Tamiflu to try to prevent the parent from also getting sick. So the difference between empiric and definitive therapy, something that they really like to test on in cardio, I believe it was, is the fact that you should draw your specimens, so you draw your blood cultures prior to initiating empiric therapy. Does anyone know why that's important? So this is important because if you start your antibiotic therapy and then you draw, right, so if you start your antibiotic therapy and then you draw your cultures, you're potentially killing the bacteria that you're looking for. Right, so you run the risk of killing off the bugs before you can even detect what it is so you can accurately treat it. So you want to make sure you initiate the therapy after your specimens have been obtained, but go ahead and do it before the results are available. That way you have some sort of antibiotic on board, preferably something that's very broad spectrum, excuse me, and you're killing things while you're waiting for the results. So once the results come back, and you know what organism you're after, then you can start with your narrow spectrum therapy. So basically your order is going to be get your blood cultures, start empiric therapy, get your results back, and then start your definitive therapy. All right, and obviously you don't need to know all these right now. I was just trying to give you some examples. I think one of the ones you're probably already familiar with is the erythromycin ointment in the newborn's eyes. So the reason they do that is to prevent if the mother has a gonococcal infection, she can transmit that to the newborn, and it can result in blindness. So that's a common one. And then also, a lot of patients will receive amoxicillin before dental procedures if they're at risk for endocarditis. So you can look over those. Okay. So the biggest thing about this lecture is just understanding the meaning of the different definitions. So like the first lecture before all the kinetic stuff, and then this lecture, those questions should be straightforward and pretty easy because it's just a lot of definitions. Okay, so the MIC, the minimum inhibitory concentration, this is what's reported on your culture and susceptibility reports. So this is the lowest concentration of antibiotic that inhibits bacterial growth. So if you get back a culture and susceptibility report and a certain drug has a high MIC, that tells you that that drug is becoming resistant to that organism. Also, you want to know the difference between bactericidal and bacteriostatic. So one trick that I've kind of used throughout the first 2 years is I will learn one thing and then remember that the other is everything else. So what I mean by that is if you can remember that your sulfonamides and your ribosomal agents, with the exception of aminoglycosides, so that's your bi at 30, cell at 50, with the exception of the A and aminoglycosides, that these two are bacteriostatic, then you know that everything else is bactericidal. So the majority of the antibiotics we're using are bactericidal, with the exception of sulfonamides and ribosomal agents. And anything that's bacteriostatic, it's simply arresting the growth and replication of bacteria rather than actually killing it. So it's giving the host a chance to kind of like get back on its feet. Okay. So why is it important that we know if a certain antibiotic is bacteriostatic versus bactericidal? Like, why does that even matter? Right. So Amy said if a patient is immunocompromised. Yeah, that's exactly right. So if you have a patient who is very immunocompromised, you may change your strategy and give them an antibiotic that is bactericidal, because one that's static is probably going to be less effective. And then I think you guys are probably familiar with nosocomial. I know that Dr. Colley used that word a lot. So basically any disease that's acquired by a patient while they're under medical care. All right. So time dependent versus concentration dependent. This is not too tough if you check out the graphs over here. So the top one is showing you concentration dependent. So in concentration dependent, there's an increase in the rate of bacterial killing as the concentration increases. So you can see that the MIC is increasing, and it's the rate is also increasing with the increase in MIC. And then time dependent is concentration independent. So even though you have a 64-fold increase in MIC, it's not really affecting the rate of killing because it's dependent on time, not concentration. Okay. So just another definition here. So the post-antibiotic effect, this basically means that a drug is going to continue to work even when the drug levels are not high. So even when things have washed out, the drug is going to keep working. It's going to keep killing. And the main reason that this is important is because you see a diminished toxicity. So you keep killing, but you don't run that risk of the drug being toxic. So if you remember, your aminoglycosides are very nephrotoxic and ototoxic. So we're especially concerned about the kidneys. So because of the post-antibiotic effect, we can do, what's called pulsed dosing, where you're only giving the drug once a day and allowing it to wash out. But you get those lasting effects, and that way there's less chance of, kidney damage. Okay. So I put in a lot of clips from first aid. I was hoping that it would save you guys some time. So all of these on here are pretty high yield. So when we talk about a superinfection, that's referring to the fact that the antibiotics kill off the normal flora, and then the bacteria that are present, but maybe not in a harmful number, will just dramatically take over. So two common examples of this are vaginal and oral candidiasis, and then also C. diff. If you guys have worked in a healthcare setting, I'm sure everybody's heard of C. diff. But the high yield thing to know is that C. diff, it often occurs secondary. So secondary meaning after antibiotic use, and it's especially associated with clindamycin or ampicillin. And then also, so the first line treatment for C. diff is going to be oral vancomycin. And you'll notice that this version of first aid still has metronidazole. I didn't look at the 2020 version, so I'm not sure if they've caught up. But like Dr. Weaver said, you'll see in a lot of places, I think including Sketchy, it'll tell you that metronidazole is first line for C. diff, but that's no longer the case, apparently. They're now recommending that you use oral vancomycin. So that tends to be pretty high yield. Let's see. And then also, last time we talked about the 4 types of hypersensitivity reactions. So the type that's most commonly associated with a drug allergic reaction, an IgE-mediated anaphylaxis, what type of hypersensitivity reaction would that be? Right, type 1 hypersensitivity. And then another drug-related reaction is Stevens-Johnson syndrome. And do you guys remember which antibiotics she talked about are associated with Stevens-Johnson? So that's going to be your sulfonamides. That's the one that she really focused on. But if you look in board resources, it's also going to tell you that erythromycin is also associated with Stevens-Johnson syndrome. And to be honest, I think there's like 100 drugs that are associated with SJS and TENS, but there tends to be a list that are like the highest risk. So like if you just Google that, like mnemonics for Stevens-Johnson syndrome, I think one is something to do with the escape plan, or I don't know. Anyways, the only one you need to know for this exam really is sulfonamides. Okay. So on this slide, I would just focus on how you prevent resistance. So washing your hands. Every patient that comes in with a cough is going to want antibiotics. You have to explain to them that it's likely viral, etc. Make sure that you're using the most narrow spectrum antibiotic. So that's your definitive therapy. You want to follow the guidelines, and then, of course, educate your patients. Okay. All right, so some practice questions. 65-year-old female patient presents to the ED with profuse, foul-smelling diarrhea and severe abdominal cramping. She tells you she recently finished a 2-week treatment regimen of clindamycin. Which drug is most appropriate to treat her current condition? So what do you think she has? Like, what's wrong with her? Or what is causing the profuse smell, foul smelling? Yeah, C. diff. So she has C. diff, and how are you going to treat it? Right, B, oral vancomycin. Good job, guys. Okay. 2-year-old female presents to the ED with sudden onset high fever and nuchal rigidity. You are worried that she may have bacterial meningitis. What is the most appropriate next step? Right, see, so you want to draw your blood cultures and initiate your empiric therapy. Then you're going to wait for the results and then switch over to your definitive therapy. Okay. When reviewing a culture and susceptibility report, which of the following is an indication that a drug is becoming resistant? Right. So that's going to be B, a high MIC. Okay. Which of the following antibiotics are considered bacteriostatic? Right, C. So sulfamethoxazole. Okay. Oh, I did want to tell you guys a funny story. So last Monday we had to take a 200 question practice Combake exam, and two of the questions on there, yeah, but here's the funny part though. Two of the questions on there, remember last time I told you guys about that TB test was an example of a type 4 hypersensitivity reaction? That was one question. And then also another question was on Gilbert syndrome. So keeping it high yield. Number 13. Do you mean slide 13? Oh, it was C. Draw blood cultures ×2 and then initiate empiric antibiotic therapy. Okay. Yeah, no problem. Okay, so going on to the cell wall agents. All right, so make sure that you review your basics from micro here. So in your gram-positive organisms, remember you have the lipoteichoic acid, and then in gram-negative organisms, you have the outer membrane with your LPS, and then, of course, a much thicker peptidoglycan cell wall in your gram-positive organisms. Okay. So, my goal with the antibiotics, I mean, to be honest with you guys, a lot of this is just brute force memorization. So, I think, I decided that the best thing would be for me to go through and like point out some of the stuff that they like to test on. So fosfomycin, I doubt you'll see that on this exam. They get into like the UTI drugs a lot during renal next year. But one that you definitely want to know all the details of would be vancomycin. So vancomycin is one of your gram-positive only antibiotics. And make sure you know this, that with IV vancomycin, you're treating MRSA versus oral vancomycin, you're treating C. diff. So why would you want to give oral vancomycin versus IV vancomycin to treat C. diff? Like what is kind of like the rationale there? Right, Amy, because the infection is in the digestive tract. Yeah, so it makes the most sense to treat it with oral vanc. So hopefully that helps you remember it if you just think about the why. Okay, and then a big one that's high yield is the Red Man syndrome. So the red man syndrome is a itchy and erythematous rash that is going to show up on the chest and the neck almost immediately after you start the infusion of vancomycin. And you want to keep in mind that this is not an allergic reaction. So this does not fall under your type 1 hypersensitivity. This is a non-IgE mediated mast cell degranulation. She also talked about in lecture, there's one other drug that causes a mast cell degranulation. You guys remember what that is? Think about something that people commonly get by IV and they get itchy. So the example she gave, was morphine. Okay. So make sure you know it's non-IgE mediated. Okay. So no, morphine's also it's a non-IgE mediated mast cell degranulation. So that means the drug itself, the drug itself is degranulating the mast cells. So it's an expected reaction from the drug, not an allergic one. Okay, so what I did with these clips from first aid is I just went through and boxed maybe some of the things that I would focus on. So again, gram-positive and red man syndrome is probably the biggest two, and then I would pay attention to any mechanism that she had in red or she stressed, so binding the diala portion of the cell wall. Okay, so beta-lactams. Hold on, let me catch up with my drugs here, or on my notes here. Okay, so beta-lactams, those are the drugs. So the beta-lactams are going to inhibit transpeptidases. Another word for transpeptidases are penicillin binding proteins that mediate cross-linking of bacterial cell walls. So this is why that we call them cell wall agents. So any organism that lacks a peptidoglycan cell wall, it's going to be resistant because the whole point of beta-lactams is to act on the cell wall. So if you don't have a cell wall, a beta-lactam is not going to work. You also want to know about beta-lactam resistance. So because of the beta-lactams, the bacteria produce what are known as beta-lactamases. So the beta-lactamases are enzymes that are going to clip the beta-lactam ring and inactivate the drug. That's why we have to add beta-lactamase inhibitors. And then also another big point down here is that MRSA has an altered penicillin binding protein. So it's going to be resistant to beta-lactams, which with the exception of ceftaroline. So what generation is ceftaroline? Yes, it's a 5th generation what? Right, cephalosporin. So that's one that I would definitely make sure that you know. Okay, so beta-lactam adverse effects. The thing that they most commonly test on from this slide is the fact that most beta-lactams are cleared renally, with the exception of ceftriaxone. So that's the reason that ceftriaxone is so popular, is that you're not going to have to monitor kidney function when you give it. And then ceftriaxone is also contraindicated in neonates because it displaces the bilirubin from albumin binding sites. So if you displace bilirubin from albumin binding sites, that results in what condition in a neonate? Like, what is that? What does that even mean? Right, it's going to result in hyperbilirubinemia and jaundice. Yeah. Okay, so trying to make it simple. So your beta lactams are the antibiotics. The beta lactamases are produced by the bacteria to inactivate the antibiotics. So what is the solution? You use a beta lactamase inhibitor along with the beta lactam to inactivate the beta lactamase. So if you're struggling with that, just read this a few times and get your head wrapped around that, because this concept here is very important. Okay, so your beta lactamase inhibitors include clavulanic acid, sulbactam, and tazobactam. So the two that you see the most common, at least throughout second year, is going to be amoxicillin clavulanate, which is also known as augmentin, and then piperacillin tazobactam is known as Zosyn. And if you're going to learn any antibiotic brand names, I would learn these two, augmentin and Zosyn, especially because during second year, a lot of the DO clinician professors, they sometimes forget that we don't know brand names, and they'll just refer to these by Zosyn and augmentin, and it's easy to get confused if you don't remember what those are. So I definitely commit the top and the bottom one to memory right now. Okay. Okay, so the penicillins. Penicillin G versus penicillin V. Okay, so as far as the route, there aren't very many that you need to worry about right now, but I would suggest knowing penicillin, G versus V. So the way I remember this is the V kind of looks like somebody's sticking their tongue out. So it looks like a tongue. So penicillin V is going to be by mouth. And then penicillin V is either IV or IM. And then a very high yield point is that you use penicillin G to treat syphilis. So it's so good at treating syphilis that even if your pregnant patient is allergic, you're going to have them undergo desensitization. That way you can treat them with penicillin G, because there really isn't an alternative that does such a good job. Okay. Do you guys know, I'm pretty sure Dr. Colley talked about this. If you have a male patient that you think they may have syphilis, how do they describe that presentation on the genitals like in a question stem? Like there's kind of a buzzword that you would look for that would give away syphilis. Like what would you see on the penis? Anybody? So I'll type it. So you'll see this, and I think I'm spelling this right. So painless chancre, or a painless ulcer on the penis. I've seen that a lot in board practice questions. That's almost a dead giveaway for syphilis. So just keep that in mind. Okay. So with your immunopenicillins, so when it says penicillinase sensitive, what does that mean? What does saying something is penicillinase sensitive, what does that tell you? Right, Haley. So penicillinase is like another word for beta lactamase sensitive. So amoxicillin is sensitive to being inactivated by a penicillinase. So if that's the case, you need to add a beta-lactamase inhibitor. So that's why you see in combination amoxicillin and clavulanate. Because amoxicillin is penicillinase or beta-lactamase sensitive, you need a beta-lactamase inhibitor to protect your drug and allow the amoxicillin to work. So that's the biggest thing I would know here. And then also, I don't know if she had this in red, but amoxicillin is commonly used in dental prophylaxis. You see that a lot. Okay. Yep, and then here in first aid, talks about syphilis, penicillin G, and then your penicillinase cleaves the beta-lactam ring. So this is its mechanism of resistance. So this is why you're going to use a beta-lactamase inhibitor. Okay. Okay, so your penicillinase resistant penicillins. So these are going to be oxacillin, cloxacillin, dicloxacillin, napcillin, and methicillin. And this is to treat any confirmed staph infection. So we're not talking about MRSA here. We're just talking about, just your run-of-the-mill Staph aureus infection. Okay. Your anti-pseudomonal penicillins, by far the most commonly used is going to be piperacillin and then combined with tazobactam to give you the broadest spectrum possible. And keep in mind, piperacillin tazobactam is very, 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 very commonly used for Pseudomonas. So this is one of your anti-pseudomonal antibiotics. Okay. I'm not sure I understand the difference between penicillinase resistant and penicillinase sensitive. Let me back up here. Okay, so if something is sensitive to a penicillinase, that means that, so just replace the word penicillinase with beta-lactamase. So if you're sensitive to a beta-lactamase, that means that the enzyme produced by the bacteria can inactivate your beta-lactam. So your beta-lactam is your drug. So if you're sensitive to being inactivated by a beta-lactamase, then you need a beta-lactamase inhibitor in order to inhibit the beta-lactamase. And that way you protect your drug from being inactivated. Does that make sense? And that's when she was talking about, sorry, I'm skipping around so much. I think I had it I have it in a practice question, but you remember when she was talking about you go in through the garage door to clip the beta-lactam ring? That's what your beta-lactamase is doing. It's clipping the garage door. Do we need to know each bacteria when there's 8 or so listed? Oh, I would do your best. I would say where it's most important is anything that covers, you want to know all the drugs that cover Pseudomonas. Know the drugs that cover staph. Those are your gram-positives. And then when we get to the cephalosporins, so 1st through 5th generation, I would say if you're going to know all the organisms, that's probably the most high yield to know. But I'll show you when we get there. Okay. Yeah, inactivation by beta-lactamase. Okay, yeah. So if you're gonna know a list, these are the ones I know. And I think these mnemonics help a lot. So for your first generation cephalosporins, also another thing she likes to do is put two drugs from the same class as an answer choice. So make sure you know all of the antibiotics that fall under first generation and all the antibiotics that fall under second generation. So first generation, if you remember, don't let the lexicon phase you. So cephalexin and cefazolin, those are going to cover gram-positive plus PEC. So Proteus, E. coli, Klebsiella. And then super, 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 super high yield is the fact that your cephalosporins are not active against Listeria, atypical pneumonia, MRSA, or enterococci. So she's probably going to give you a question stem that describes one of these presentations, and then she's going to say, which antibiotic should you use? So you're not going to use a cephalosporin to treat any of these unless it's MRSA and you're talking about Septaraline. So definitely know that. Okay, and then, so third generation, you're going to get HIN plus your pneumococci, and then ceftazidime is anti-pseudomonal. Kind of a trick for this, ceftazidime covers Pseudomonas. And then also don't forget, ceftriaxone is not cleared renally. So it's very popular because you're not going to have to monitor renal function. So if you get a stem with a patient who basically has a lot of kidney problems, ceftriaxone might be an acceptable choice because it's not cleared renally. So it's going to be safe for that patient. So that's kind of a way that she could present that in a question stem. Okay, and then you'll notice here I left out the M because your fifth generation cephalosporins are going to be active against MRSA. Okay. Okay, so your carbapenems. This one tends to be a little bit easier because they all, or this class, I guess, tends to be a little bit easier because they all end in penem. So imipenem, ertapenem, doripenem, and meropenem. Something that's pretty high yield, but I don't know if she hadn't read, but just for in the future, if you remember skirts around Pseudomonas, then you'll know that ertapenem is not effective in treating Pseudomonas. And then also a very common adverse effect with carbapenems is going to be seizures, and that's the highest with imipenem. And then one last thing, so cilastatin is added to imipenem to prevent deactivation by dipeptidase in the renal brush border cells. So basically, you add cilastatin to prevent the drug for imipenem from being deactivated. And the common way to remember this is the kill in is elastin with cilastatin. So that's going to help you remember that you're adding cilastatin so imipenem can keep killing the bacteria. Okay. Aztreonam, most important fact is that it's one of your anti-pseudomonal agents. Okay. So, practice questions. A patient was being treated for systemic MRSA infection. During the drug infusion, she began to experience flushing of the skin, itching, and an erythematous rash over face, neck, and upper torso. How would you describe the reaction being caused by this drug? Right, so you guys are correct. It's a non-IgE mediated mast cell degranulation, excuse me. And what is this question stem describing? What drug did the patient get? Yeah, vancomycin and right, and red man syndrome. Yep, good job. Okay, so here we go. Where do beta lactamases, so beta lactamase, the enzyme produced by the bacteria, clip the beta lactam, which is the drug's ring, right? D. So the question last year on the exam looked basically just like this. It's just going to give you some arrows and, where is it happening? So this should be that's why I put a star here. This should be like a really easy question to get right on the exam. Yeah, so it's going to clip right here at D. And so because of that, you're going to add a beta lactamase inhibitor to make sure your beta lactam is still effective because it's going to get rid of the beta lactamase. Okay. A patient in the ER is diagnosed with pneumonia and empirically started on piptazo and vancomycin to cover Pseudomonas and MRSA. Cultures from the lab show methicillin susceptible Staph aureus. So what definitive therapy should the patient be on? This is a harder question. I'll just give you that. Right, you guys are getting it though. Yeah. So the correct answer is C, nafcillin. Okay, so vancomycin covers MRSA, but the lab showed methicillin susceptible, not resistant MRSA. And then piptazo is covering Pseudomonas, so you can get rid of that one. And then so nafcillin, that's your oxdicloxmethanaf or anti-staph. So the correct answer here is going to be nafcillin. Okay. 40-year-old male in the ICU is being treated for traumatic brain injury and has been on a ventilator for 9 days. He is now diagnosed with ventilator-associated pneumonia. The physician wants to start empiric therapy that covers gram-negative pathogens, including Pseudomonas. What is the best choice for empiric therapy? Right, good job. Sepime. So if we change this around a little bit, what fluoroquinolone could I give you as an answer choice that would cover Pseudomonas? Right, ciprofloxacin. Okay. One more here. A 21-year-old female is admitted to the ICU with severe intra-abdominal infection. She has a medical history of epilepsy and is currently being managed on lamotrigine. Which antibiotic should be avoided in this patient? Right, Haley's got it. So imipenem. So remember your carbapenems. You have an adverse effect of seizures, especially with imipenem. It's an anti-seizure drug. Okay. All right, so going on to the protein synthesis inhibitors. All right, so my advice here is to learn your buy at 30 and sell at 50. And then at that point, you should know enough that if they ask you about the mechanism of action, that you're probably going to get it correct. So your aminoglycosides and tetracyclines, their mechanism of action involves the 30th ribosomal subunit, and then your macrolides and these last three involve the 50th ribosomal subunit. Okay, let's see what else here. I would also remember that aminoglycosides are nephrotoxic and ototoxic. They could definitely give you a question stem describing somebody who, you're rounding and they're like, hey, doctor, I'm suddenly having a lot of ringing in my ears. And then they'll say, which of the following antibiotics is this patient most likely taking? And, it's going to be one of the aminoglycosides most likely. For tetracycline, a commonly tested adverse effect is going to be photosensitivity. So she gave you, yes, Haley, vancomycin, also nephro and ototoxic. She shouldn't have both of those as answer choices, though. I think aminoglycosides are known even more so for that, though. So for tetracyclines, she gave you a mnemonic of antibiotics that have an adverse effect of photosensitivity. Do you guys remember what that was? Right, the sun fries. And what does that stand for? Right, tetracyclines, fluoroquinolones, and sulfonamides. So they could describe photosensitivity in a question stem and then give you a specific drug in that class. So instead of, one of the answer options being tetracyclines, it might be doxycycline, or you might get like moxifloxacin as an answer possibility. So now, know the mnemonic, but also know the drugs included in those categories. Let's see. Another common one is the gray teeth. So tetracyclines are chelators. So anytime new bone is laid down, so especially in young children having their mature adult teeth come in, you don't want to give them tetracycline because they'll end up with gray teeth. Okay, we're good there. Will they give us the bacteria name? Oh, I would say no. No, you don't need to remember everything from micro. They will either give you the bacteria name or they'll give you a common presentation of the bacteria, like syphilis and Treponema pallidum. You know what I mean? They're not going to be like, the bacteria is oxidase positive, blah, 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 all the small details. Yeah, like I said, Dr. Beaver is very fair. Yeah, I mean, I would like try to remember something, but she's not going to get you on the small details of micro. Definitely not. Okay. Keep going here. All right. So, a 40-year-old male in the ICU began a regimen of amikacin to treat a complicated Pseudomonas infection. The pharmacy student is rounding with the critical care team and is asked what the mechanism of action is of amikacin. What should her response be? Right, you guys got it. So the answer is C. Bind irreversibly to the 30th ribosome, interfering with the initiation complex of peptide formation. I would expect at least a question or two testing your knowledge of the mechanism of action. Like, you're not going to be totally, hosed if you don't know them, but I would at least try to know the ones that are in red, and put it that way. Because they'll probably do something like this at least once or twice. Okay. 67-year-old female admitted to the hospital with severe diabetic foot ulcer, history of acute renal failure, and currently in stage 2 chronic kidney disease. Which antibiotic is the best choice for this patient? Right, good job, you guys. So the best choice is going to be ceftriaxone, and why is that? Right, Hayes got it. So it's not cleared renally. I would definitely remember that. Okay, one more here. Okay, so DNA and antimetabolites. All right, I'm going to go ahead and skip to this right here. So be able to draw this out on your exam. You'll get at least one question like testing your knowledge of this. So levofloxacin and moxifloxacin are both considered respiratory fluoroquinolones. And then levofloxacin and ciprofloxacin cover Pseudomonas. So she talked about it in lecture. A lot of hospital formularies will just have levofloxacin because you're getting both a respiratory and pseudomonal coverage here. So I would make sure that you know this, and that should get you a point on the exam. Okay. And then also tendinitis and tendon rupture. This is something that they hit on a lot as far as an adverse effect of fluoroquinolones. Okay. Make sure you know that your sulfonamides can cause hemolytic anemia and G6PD deficiency. And then also make sure you know how G6PD deficiency presents. If you look at the last tutoring PowerPoint, I kind of copied one of her practice questions. So on our exam last year, they showed us a like pathology or what do you call it, like micro slide of the bite cells, those little cells that look like they have a bite out of them. And they're giving you a hint by doing that, of course, that they're talking about G6PD deficiency. So I would go back and look for that image and make sure you can recognize that in case it shows up on the exam again this year. Okay. Oh yeah, and then also Stevens-Johnson syndrome is associated with sulfonamides, especially in slow acetylators. And then your sulfonamides, one of your adverse effects is photosensitivity. So, make sure you remember the sun fries. Okay. And then here's another one involved in G6PD deficiency, so nitrofurantoin. And then metronidazole. Okay, so this is one, usually most board questions involving metronidazole, they're either talking about a below the belt infection, which, she didn't have in red, so don't worry about that. The thing I would worry about right now is your disulfiram reaction. So if you're inhibiting aldehyde dehydrogenase, you're messing with, ethanol metabolism. So basically, if someone is drinking and taking metronidazole, they're going to be very sick. So, and that's what's known as your disulfiram reaction. So something, if you prescribe a patient metronidazole, you definitely want to caution them on drinking because that can make them very sick. So this disulfiram reaction, we were actually just tested on this again in Repro too. Okay, let's see, the last thing, make sure you know that rifampin is effective against mycobacteria. So something they talk about a lot is what's known as RIPE therapy. So RIPE therapy is rifampin, isoniazid, what else is it? Pyrazinamide, I think I'm pronouncing it correctly, and ethambutol. So that's RIPE therapy, and rifampin is always used in the treatment of TB. And this is something that you're going to see a lot, especially next year. Okay. So I'm just trying to give you guys like the most high yield stuff, like the stuff I'm pointing out. I don't want to, just sit here and read this chart to you guys. Okay, and then I highlighted them here for you. All right, so one more question. Which antibiotic does not cause photosensitivity? Great, good job. So linezolid. So remember, this, of course, they can't ask negative questions, but this is an example, whereas instead of giving you saying fluoroquinolones, it says, you're giving an example of fluoroquinolones, so levofloxacin. Okay, so I'm not sure why she doesn't just teach this up front, because I think you guys have been exposed to 5-fluorouracil in MFM1. But the mnemonic you're going to see for boards is the sun fries at 5. So 5 FU is also, I guess because it's not antibiotic, but yeah, just so you know, the complete mnemonic is the sun fries at 5. If you want to go ahead and, get that in your brain. All right, well, that's all that I've got for you guys. So my plan on Sunday is to cover the last 2 and then hopefully get some more practice questions out. Yeah, you're welcome. Thanks, I appreciate it. Good luck to you guys too. I promise you it gets better after endocrine. Things are gonna get a lot better. Thanks, guys. Have a good night. Yes, things get so much better when physio ends. I mean that in the nicest way. No offense to physio professors, but life does get better after physio. All right, well, I'm gonna log off. I'll see you guys later.